Welcome, everyone. We're going to start in 1 or 2 minutes. We'll just let people come in and start. Please stay off camera and muted because we are recording this webinar. Okay, let's start. I'll let people in as soon as they come in, but we can start. I know everybody has a tight schedule. So, good afternoon, everyone, and welcome to another session of Your Fertility Guide, Fertility Friends Foundation's free educational webinar series designed to help patients navigate their fertility journey with trusted, evidence-based information from leading experts. My name is Isabelle Lefebvre-Vary, and I am the Executive Director and co-founder of Fertility Friends Foundation. Before we begin, I would like I'm so sorry, I'm letting people in at the same time. So before we begin, I would like to extend our sincere thanks to EMD Serono, the proud sponsor of Your Fertility Guide webinar series. We are deeply grateful for their ongoing support and commitment to helping fertility patients access high-quality educational resources. Through their support, we are able to continue offering these webinars free of charge to our community. So thank you so much to EMD Serono. For those of you who may be joining us for the first time, Fertility Friends Foundation is a Canadian registered charity dedicated to helping individuals and couples overcome the financial barriers associated with fertility treatments. Through our grant programs, educational initiatives, and support services, we work to ensure that more Canadians have access to the care they need to build their families. We are especially excited right now because we have just completing our spring 2026 grant cycle, and I'm very happy to announce that we have awarded 19 grants of $5,000 each to 17 individuals and couples who would not have been able to start or continue their fertility journey without our financial support. We are incredibly proud of this achievement and being able to support these families as they move forward on their path to parenthood. Today's topic is one that generates a lot of interest. We had many people register to this webinar today, and sometimes it creates a bit of confusion. When you walk into any pharmacy, health food store, and browse online fertility forums, you'll find a lot of options in terms of fertility supplements. And sometimes it's very difficult to make informed decisions, know more about what's useful for yourself, for your own case. That's why we decided to organize this session today and contacted Dr. Jennifer Fitzgerald, who is a naturopathic doctor and founder of Conceive Health in Toronto. Dr. Fitzgerald has helped a lot of individuals and couples optimize their reproductive health through evidence-based naturopathic care. She is widely recognized for her expertise in fertility, preconception health, IVF support, and reproductive wellness. Today, Dr. Fitzgerald will help us separate fact from fiction as we explore fertility supplements, what the science says, and what you should know. Thank you so much, Jennifer, for being with us today and for giving your time to our community. That's very, very precious. And before I let you start your presentation, I have a few housekeeping notes. This meeting is recorded So you should stay off camera if you don't want to see yourself on our YouTube channel, and also mute yourself. That would be best. So Dr. Fitzgerald can go through her presentation without any disruption. You can ask your questions through the chat at any time. Jennifer will be monitoring the chat and myself as well, and she will answer questions during the presentation. So that's it for me. Thank you again, Jennifer, for being with us today, for your time, for your support of Fertility Friends Foundation. You are a true friend of the organization, and we are very, very happy to welcome you today. Thank you.
Thank you. I'm really happy to be here, and I'm so happy to be a friend of the Fertility Friends Foundation. So I appreciate the invitation today, and I will right now try to get started here right away. So first, a bit about me. That was a lovely introduction, and I don't think you missed a whole lot. I'm a naturopathic doctor in Toronto. I co-founded a clinic called Conceive Health about 15 years ago, and that's an integrated clinic that's in a fertility clinic. So I work with IVF doctors and patients, and basically every stage of the fertility journey. So I have patients that are, just starting out and making plans, all the way to those that are in the depths of fertility treatment. Outside of my clinical practice, I do some product formulation. So that's a bit of a disclosure and a disclaimer about me. So there's some maybe some inherent biases there. I've done product formulation for two major companies, Bird and Bee and BioClinic. I am originally from Nova Scotia, the east coast of our beautiful country. I miss it dearly here in Toronto, but I do visit as much as I can. I'm also a former fertility patient. So I am a mom of two, but I also experienced recurrent pregnancy loss. I think somebody's, there we go. And so I have been sort of on both sides of the desk as the fertility patient and the fertility doctor. And so I bring to the table some experience from both sides of those things. So to start out, I'm just going to review what we'll cover very quickly here. We're going to talk about why nutrients matter. We're going to talk a little bit about the preconception window. We're going to review some foundational supplements and some more targeted things, some safety and smart choices. We're going to do a Q&A at the end. And as always, this is not intended to be medical advice, and you should consult a professional for individual recommendations, okay? So things to start out with. So supplements are very widely used. In some studies, over 90% of fertility patients are utilizing some type of vitamin or supplement. And so what that study also says is that about 70% of those patients are self-prescribing these things. And so that can be a bit risky. There was 41 moderate risk supplement medication interactions identified in this particular study. And that's really concerning, right? When we do fertility treatment or we're trying to get pregnant, we're trying to do the best thing for us and not try to create more barriers. So very important to make sure we're taking clear and safe things. In Canada, supplements are very tightly controlled. They have something called an NPN number, which is a nutritional product number. Every product that's for sale in Canada on the shelf that's a nutritional product will have this number. It is not an easy number to get. It costs bazillions of dollars, not really thousands of dollars, to get an NPN number for a product. Every single ingredient has to be well researched, and then the combination of ingredients. So it's actually very tricky. If we look at our, say, neighbors to the south, the FDA does not have the same type of regulations in place. So my recommendations for patients are to stick with Canadian-based products. We know they've been verified and third-party tested and all of the things. We have various types of supplements in terms of over-the-counter versus professional brands. They might vary based on bioavailability or dosages or things like that. But at the end of the day, wide variety of different products available. We have products that are targeting what we call the RDA. So things like multis or prenatal, so recommended daily allowances, making sure we get the basics. And then we've got things that are in more therapeutic dosages. So these are going to be more targeted things. Supplements vary in their absorbability, so how your body absorbs it into your body. So things like iron, for example, different forms of iron will have different absorbabilities in people's digestive systems. And then bioavailability is a thing as well. So maybe, for example, there's active versions of some nutrients and inactive versions, and that can make a difference in some patients as well. We also want to pay attention to fillers, artificial coloring, dyes, additives. So those are the things we don't really want in our supplements. We want to keep them as clean as possible, just so we're not adding extra layers of problems. And then also important that not all natural agents are harmless. And so these things do have side effects. They are used to treat diseases, deficiencies, illnesses, and they do interact with medication sometimes. So we have to be cautious. So why do nutrients matter for fertility? So basically, these foundational nutrients are involved in every single step of making a human. So from cell division, DNA synthesis, which is going to be important for both egg and sperm and embryo. Nutrients impact our hormones. So vitamin D, for example, is a nutrient, but also basically acts as a hormone and has a lot of hormonal properties. Energy production. So our food is fuel, right? We are, in fact, what we eat, and we use these building blocks of our diet and our supplements to make energy. And that is very important for our cells, egg and sperm, as we will learn. Nutrients matter for our immune function. Think about vitamin D, omega-3, those types of things are critical for immune tolerance. And then for early development, every single nutrient from A to Z is required for fetal development. So we do really need these things. They're not an option or a choice. Can't I get everything from food? Food always comes first. Preferentially, we would get everything from food if we can, but unfortunately, nutrient gaps are pretty common and they do exist. And that's because individuals have different needs. Our absorption might be different, our dietary preferences might be different, and we even have different pre-genetic dispositions that are going to interfere with how our body handles food. So things like folate, maybe that's reasonable to get 400 micrograms of folate every day. You've got to eat maybe some spinach and some lentils and a combination of products. To get 1,000 IUs of vitamin D, it's a bit tricky. Like, I don't know a single human that's going to eat 50 eggs for breakfast, or 10,000 bell peppers to get appropriate PQQ, or 4,000 cups of cherries for any means, right? So this is where, yes, in some cases we can get enough vitamin C from our food, but potentially when we're trying to hit therapeutic doses of things, it's not going to be adequate. And we see this with things like iron deficiency and vitamin D deficiency all the time. So the 3-month preconception window, so this refers to the period of time leading up to a conception. So this is the period of time where our eggs and sperm are maturing. So as females, we know the story, the eggs have been with us for the long haul, but they wake up basically about 90 days before a conception, and that's when they start to mature. Sperm, on the other hand, are going through a full spermatogenic cycle in the same period of time. And during that window of time, this is sort of what I call the window of opportunity. This is where these cells are going to be the most vulnerable to their current environment. So they might be influenced by nutrient changes, if we have inflammation in our body, or oxidative stress, how much we're sleeping or not, exercising or not, our metabolic health, toxin exposures. Age is another one as well. What I will point out is that the majority of these things are modifiable risk factors. Obviously, we can't modify our age, but all of the other ones are things that we can modify with diet and lifestyle. So why does oxidative stress matter? So first of all, oxidative stress refers to an imbalance between what we call free radicals or oxidative stress and antioxidants, which are nutrients or other factors that provide some cellular protection. So our life is truly like a little balancing act here. We see our little scale off to the side. So we are trying to keep our antioxidants and our oxidative stress in balance. And as we age, the oxidative stress increases and our ability to make adequate antioxidants decreases. So we want to try to balance out these scales for as long as possible. So what causes oxidative stress? Normal everyday things can cause some oxidative stress, and that is normal. So it is normal to have some level of oxidative stress, but when we have too much, that's when things can go sideways a little bit. It can affect things like DNA, can cause damage, can damage our mitochondria, and that can interfere with egg and sperm quality concerns. So that's why we care about oxidative stress. And so what the heck are mitochondria? Because I mentioned that in the last slide. So mitochondria are like the little energy centers or powerhouses of the cell, like our little engines. So they are in high quantities in eggs. Eggs really rely on a lot of energy from these mitochondria. Sperm rely on mitochondria as well. We find them in the neck of the sperm, and they're responsible for things like motility. And then when we fertilize an embryo to create a human, the maternal mitochondria are what make it into the embryo, and that's what provides a little bit of energy for that early embryogenesis. So this is why mitochondria matter. When we have high functioning mitochondria and energetic cells, we make more efficient eggs, sperm, and embryos. So what can supplements do and what can't they do? So supplements do things like correcting deficiencies. So we talked about iron deficiency and vitamin D deficiency and things like that. They can support normal physiology, so normal cellular functions like mitochondrial function, which is what I just talked about, and they can reduce things like oxidative stress. And by doing those things, so by improving mitochondrial function, correcting nutrient deficiencies, decreasing oxidative stress, that's where we get the benefit from the egg and the sperm health, okay? So we can't say that eggs and sperm are fixed by antioxidants. What antioxidants are doing are lowering oxidative stress, improving mitochondrial function, and helping those cells to function better. And then hopefully we get better quality cells at the end of that equation. What they can't do, obviously they don't guarantee pregnancy, right? We know that these are not a sure thing. They don't fix every cause of infertility. So for example, they don't override age or structural issues or blocked tubes or genetic issues or things like that. They're supportive care, and they don't replace medical care or diagnoses. So they're here for support. So let's get into the good stuff here. So these are what I refer to as the foundational nutrients. And so for many people trying to conceive, this is going to come from a prenatal or maybe a multivitamin. And so we all have different food sensitivities, preferences in terms of our diet, health issues, genetics, and that impacts how our body might handle specific nutrients. So your prenatal vitamin or your multivitamin is kind of like the insurance policy, and that just ensures that we're getting these essential nutrients on a daily basis. So some days we might eat really well, sometimes not. The prenatal or the multi really ensures that is, we're getting those basic requirements. Nutrient deficiencies are actually quite common. So for example, like it's up to 50% of females that are iron deficient in Canada. 70% of Canadians are generally deficient in vitamin D. So these are real things that happen in a lot of people. They're not just, once in a while or things like that. We see them every single day in clinical practice. So these are sort of those things that make sure we get those bare minimums. And then sometimes we'll need to top those up in certain individuals as well. Beyond folate, we hear about folate a lot, but all nutrients are required for egg and sperm health and for creating a healthy baby. So making sure we either have adequate dietary intake or utilizing a prenatal or a multi is sort of the intention here. And so in our prenatals in Canada, they're all going to have some similar ingredients, and then there's going to be some variation. So they all have some folate, they all have some B12, they all have some vitamin D. Most of them are going to have iron unless it's a a gummy or a powder or something like that. And so that's sort of this foundational product. In Canada, the most common nutrient deficiencies that we see clinically: vitamin D, vitamin A, calcium, magnesium, and iron. The biggest difference between your multivitamin and your prenatal vitamin is the addition of iron. And then a lot of prenatals will have a little bit of extra folate as well. But sometimes I'll get those patients coming in, they have thalassemia or iron overload issues or something along those lines, and they're trying to avoid iron. And that's where I might lean into, say, a multivitamin or an iron-free prenatal in those circumstances. For the most part, women generally are going to need a little bit of iron. That's a generalization. What about men? So we don't often talk about men and prenatal vitamins, but they make up 50% of the DNA equation here. They're just as vulnerable to nutrient deficiencies as females are, and we really should be advocating for multis, or we won't call them prenatals for men, but making sure we have that basic nutrient intake. When I'm choosing prenatals for my patients, just as a last note here, I often use blood work as a guide because they are also widely different. Any prenatal, like I said, is going to have those basic nutrients. So if we're just starting out, pick the one that you can take and have no side effects for. That is the most important thing here. And then, there are times when we might need somebody might need more B12 or something specific that we might be able to accommodate with a prenatal. And that's where I'll start kind of playing around and picking different ones based on the formulations. But in general, there's overlapping similarity between a lot of these things, and they will cover the basics for the majority of us. So let's talk about folate for a minute. This is probably the most well-known nutrient. We know that we need to start taking this one prior to pregnancy. It is not just for women. That is a very big misconception. And so yes, we want it in a female partner, ideally 3 to 4 months prior to conception, which helps us reduce risk of things like neural tube and spina bifida. But it's also because it's in there to support the cell division in that maturing egg that's going to become your baby later on. And the same is true for sperm. We have a whole set of DNA in sperm that has to be protected and supported as well. And so folate is important for men as it is for women. About 400 micrograms is the RDA for men. And the main goal here is just getting adequate folate intake. So whether that comes from a prenatal vitamin or whether it's coming from a folate supplement separately, it really doesn't matter as long as we're getting that basic requirement. So folic acid is so important that we fortify our food supply here with it in Canada, right? So if we're eating grain-based products, we do get some folate. We still see deficiencies. We still recommend everybody take it. So these are the RDAs, so the recommended daily allowances. This is the minimum amount that we need to get the job done. That's what a daily recommended allowance is. It's not like a whole lot to spare here. So these are minimum requirements. Sometimes we recommend a little bit more depending on certain situations, but we just want to make sure we're getting that main adequate folate intake. So it's for DNA, cell division, neural tubes, spina bifida. This is the most important one. We got to start at least 3 months prior to conception, ideally. Both partners. Okay. The rest of the things, so if somebody stopped me on the street and asked me what I should take if I was going to try to have a baby, my answer every single time would be a prenatal or folate, adequate levels of vitamin D, and an omega. And here's why. Okay, so vitamin D, very commonly to be low. Canadians, about 60% of us in the summer, 75% of us in the winter are actually deficient. Vitamin D is necessary for things like fertilization, implantation. I mentioned it acts more like a hormone than actually a vitamin. So it's involved in a lot of our hormone regulation, hormone receptor expression, things like that, immune tolerance. So our immune system accepting implantation and allowing pregnancy to happen. And even when we are getting the basics, even when people are supplementing the 800 or 1,000 that Health Canada is recommending, a lot of us are still low. A lot of us are still low. So this is one where I do recommend asking your doctor to check your levels if you're starting to try to have a baby and just get a pulse check on that one. We titrate it to where we need it. In general, if you don't have a healthcare provider, you can go into Life Labs in Ontario. If you're not in Ontario, it might not be true, but you can go into a Life Labs, no requisition, and get a vitamin D test. You can order them online. Most patients are going to need between 2,000 and 4,000, so that's a good place to start. Iron, again, one of the most common iron nutrient deficiencies we see in Canada. High and low iron levels are impactful for both egg and sperm. So this is, we call it the Goldilocks nutrient sometimes, not too much, not too little. Serum levels are important here as well. But it provides oxygen. Oxygen provides energy. So whether we're talking about eggs or sperm or embryos, all of those things are going to require iron and the oxygen that the iron helps to bring to those areas of our body. Women menstruate, so they lose a lot more blood, and that makes us more prone to iron deficiency than males. However, there's a lot of risks involved. So dietary intake, genetics can all impact iron levels. And so making sure we have adequate iron is what's important here. And then omega-3. So omega-3 is involved in fetal brain and nervous system development. It also makes up the outside layer of some of our cells. So egg cells and sperm cells require a lot of specific receptors to create fertilization. And so omega-3 is very, very critical for fertilization. It's one nutrient that does not have an RDA attached to it outside of pregnancy. So in pregnancy, we know we need approximately 200 to 300 minimum of DHA. We do recommend more than that generally, just because we don't have an established number. And we still recommend it in men as well. So there's some evidence that having increased levels of DHA in men improves fertilization with sperm as well. So making sure we have adequate intake. of omega-3. So to wrap up that foundational few slides there, we want to start with the basics. So we want to start with something like a prenatal or a multi or something with folate in general. So that's step one. We want to ideally have some vitamin D in there as well. If we can get our levels checked, that's fantastic. If not, take the recommended amount. And then omega-3, especially if your intake is low. So the Health Canada guidelines are to consume fish 2 to 3 times per week, and then to take 300 milligrams of DHA per day for fertility and pregnancy. So that's the bare minimum that we require from that perspective. So if we're not incorporating fish in our diet, especially, we should be looking for an additional omega-3 source, which is usually a supplement. So there are some prenatals that will tie all of these things in nicely together. So you'll find prenatals sometimes that have 1,000 IUs of vitamin D with a little bit of omega-3, 2 to 300 milligrams added in. So those are really great places to start as well. Iron traditionally is going to be in your prenatal. There's between 18 and 27 milligrams of iron in most prenatals in Canada. And so we add additional iron if and only if it is needed in that case. And so that would require a serum test to decide if that was needed or not. But in general, I don't do additional iron on top of the prenatal unless it's required. Not all prenatals will contain iron, so watch your labels. The gummies, the powders, those are in general not going to have iron, or if it's marketed as like a gentle formula for nausea, it probably excludes the iron. So just something to keep in mind there. Okay, so we're going to move into some more targeted stuff here. And so this is when context matters a little bit more, because not everybody's going to need all of the different things, right? So we start with the basics, especially if you're not on a prenatal yet, we start back at foundation. If we've already been doing this for a while and maybe we've already started some of these things, or maybe we're just starting out in our fertility journey and we don't, identify with a diagnosis or anything like that. Again, starting with foundation is where I would recommend. Now, when we get into some more advanced stuff, maybe we are older in age, maybe over 30 or 35 in general, over 40 especially. If we have diminished ovarian reserve, so that could be premature ovarian insufficiency, or it could be older females. Male factor infertility, so having diagnosed low sperm parameters. PMOS, or former PCOS, has been renamed. This can cause some need for some extra nutrients as well. Unexplained infertility, so when all the testing is normal, sometimes we lean on supplements to try to improve outcomes. Patients that are prepping for IUI or IVF cycles, it can be impactful, and patients potentially experiencing things like endometriosis. So again, we're talking specifically about antioxidants and mitochondrial nutrients, which reduce oxidative stress and improve mitochondrial function. And that's how these things can potentially impact our fertility. So getting into some specific supplements here, a lot of patients have heard about CoQ10 or coenzyme Q10. This is probably one of the most researched antioxidants for both egg and sperm function, probably the most recognized by patients from the antioxidant side of things. It plays a direct role in mitochondrial energy production, and it's also a really potent antioxidant. So improving that energy churn, decreasing the oxidative stress. Since egg and sperm are both highly energy dependent, an age-related fertility decline is associated with more oxidative stress, slower mitochondrial function. CoQ10 goes in there and helps to reduce the oxidative stress and churn out more energy. So therefore, we see it benefiting in potentially things like advanced age, pregnancy loss, overall egg quality support, overall sperm quality support, and things like IUI and IVF prep. I get asked a lot about ubiquinone versus ubiquinol. If you've never heard of this, don't overthink it too much. These are the different forms of CoQ10. And so if you look on the nitty-gritty print on the labels, it might say which form your coenzyme Q10 is in. Important to note, all of the studies are done on basic CoQ10, the ones on egg quality. They're all done on ubiquinone. There's not one single study on egg quality and ubiquinol so far that I have seen. And then so basically the claim to fame here is that some professionals are saying or suggesting that ubiquinol has a better absorbability or more bioavailability. That has not been proven. So there's 2 studies. One of them is on 20 men, that were over 55 years of age. And they tested the ubiquinone versus ubiquinol. The other study was done on, it was like 6 men, 6 women. They were above 45 years of age. Neither one of these were for fertility, and they were short-term use, just sort of looking at serum levels. And so there's, in terms of what we know about fertility and CoQ10, there's no difference. So regardless of which one you have, it should be fine. I don't usually suggest overpaying for ubiquinol when ubiquinone tends to work just fine. I'm just looking at the question that just came in. Gastric sleeve for bariatric surgery. Typically, some of the fat-soluble nutrients and things like that are the things we need in higher amounts for those. So yeah, there's typically specific multivitamins for patients that have had sleeves or bariatric surgery, and they have higher dosage ranges of those specific nutrients. So usually I'll still go with those specialized like multivitamins for those types of patients. Great question. So this is about CoQ10 specifically in terms of studies on fertility outcomes. And so it's one thing to say that a supplement can improve mitochondria and reduce oxidative stress, but put your money where your mouth is. Does it actually work from a pregnancy outcome or live birth rate, those types of situations? And really the jury's out on a lot of these things. So what we know from a female fertility perspective is that it does improve response to ovarian stimulation. So that's in IVF patients. It improves their overall response to the medication. It improves egg quality and embryo quality in women that has diminished ovarian reserve, so lower egg numbers. That's generally going to be older women, but not always. And that typical dosage range was about 600 milligrams per day. What happens with most things in the research world is they start out with animal-based studies and then they move into human-based studies. Takes a lot longer to get human-based studies, which is why we have so many more limitations on these types of things. So we see things in animal-based studies like improving spindles in the eggs and improving the aneuploidy rates of the embryos and things like that. But we can't translate that over to human medicine. Humans are not mice at the end of the day. So we have to sort of take animal data, extrapolate it, and then try to regurgitate it in human data. And unfortunately, that takes a lot longer and it's a lot more complicated. So we have less information for sure. In terms of the male fertility, so sperm is a little bit easier to access than eggs, if we can understand. So it's a little bit easier to do testing on sperm. And so we do see that CoQ10 increases the total antioxidant capacity in sperm. That was using a dose of about 200 to 400 milligrams. And most of the references with sperm show an improvement in the sperm concentration, that should say, not just increased sperm. Also the motility and also the morphology. So really what we see clinically, at least, is we usually see it improve all sperm parameters in most cases if it's because of oxidative stress. Now, if somebody has low sperm parameters because of a genetic defect or a blockage, supplements are not going to fix that. So moving into another antioxidant that we hear about and we might see in a lot of different fertility-based formulas is one called L-carnitine. It's sometimes called acetyl L-carnitine. Those are slightly different forms. In general, they're going to do the same thing for fertility. Maybe L-carnitine is slightly more beneficial here as the antioxidant, the more powerful antioxidant. So this one has more data in male factor fertility. And it's involved in sperm maturation. It's been shown to improve all sperm parameters. And the dosage range used in the studies of this one was about 2 grams per day. Now, clinically, we use anywhere from 500 milligrams to 3,000, so it can really depend. But you'll find this one in a lot of the fertility formulas, and this one does have evidence that it can improve sperm parameters. From a female side, it's less studied in females, as most things are, just because eggs are a little bit trickier. But in a study on IVF patients specifically, it did show an improved oocyte or egg maturation rate, embryo formation, and it did improve the live birth rate in that particular study. So that's very encouraging for carnitine. And they did not disclose the dosage used in that study. I will point out for the females, generally, clinically, we're using about 500 to 2,000, just sort of depending on the case. Melatonin. So melatonin is our sleep hormone. We make melatonin at night when we're going to sleep. And so not only is it a sleep hormone, it is a very potent antioxidant. It's actually made locally in our ovaries and in our testes if we have them. And so it is very important for reproductive health as well. And so I could go on probably all day about the different things that melatonin can do in terms of reproductive health. But it is, like I said, a potent antioxidant, and it does help to modulate some some hormone production and things like that happening in both men and women. So from a male factor fertility perspective, it enhanced the antioxidant capacity and significantly reduced the DNA sperm damage. In females, we see improvements in egg and embryo quality, improved fertilization rates, and pregnancy rates. In this one little study here that I noted, they used about 3 milligrams. So the studies are generally using 3 to 6 milligrams leading up to an egg retrieval in this particular case. In a preconception plan, I might use it for, say, a 3-month period of time leading up to conception, just depending on the sleep patterns of the individual as well. N-acetylcysteine, or NAC. This is another example of an antioxidant that's widely used in fertility. It is the precursor to something called glutathione, which is the main antioxidant that our body makes. It's made in our liver. And so as we age, our body reduces glutathione production a bit. So this is kind of an anti-aging strategy a little bit. But when we add NAC, it's the immediate precursor to glutathione. It helps our body make more of glutathione, which is that master antioxidant. So it really helps us reduce oxidative stress. And the other thing that NAC is known to do is impact insulin resistance and insulin sensitivity. I see insulin resistance perpetually in my practice over and over and over again. It's a major metabolic lifestyle factor in the Western Hemisphere. So I think that's something that we need to pay attention to, but NAC can improve insulin sensitivity. We also use it for some kind of off-label things, like there's some potential for it thinning out cervical mucus and seminal fluid. So if we see agglutination in the sperm sample or thicker cervical secretions, we might think about NAC. We use it a lot in PMOS, male factor fertility. And in general, it's been used for things like thin lining, poor cervical mucus, PCOS in females, and then just sperm parameters. It's less studied in men. For sperm. So I think there's a couple of bigger studies that showed a little bit of improvement. Definitely more research on females and definitely more research in PCOS or PMOS for this one. So now I'm going to walk you through some scenarios a little bit. So those are some of the big guys that we use and the ones that are probably the most evidence-based supplements that we have going on. All right. And so when, how, where would we use these types of things? That's what I'm kind of gonna try to clarify just a little bit. Yeah, not everybody's gonna need all the things. Everything kind of comes in stages. So for egg quality, if we're planning to get pregnant for the first time, if we're over 30 or 35 or even over 40, if we are maybe going through some fertility treatments, or we have underlying issues. So maybe we already know we have insulin resistance, or we have inflammation from an autoimmune disease, or something else is going on with your health. So starting out, foundation always, prenatal, vitamin D, omega. I always start with those basics, and then we might want to consider some antioxidants in these scenarios. So CoQ10 is probably the first thing I would take if you were going to take anything at all. It would be the CoQ10 that I would add, and then plus or minus 1 or 2 of the other things might be impactful here. Why are they used? Again, oxidative stress increases with age and our mitochondrial function declines. So the combination of those two things requires more mitochondrial nutrients and decreasing the oxidative stress. Similar idea for sperm. Sperm are influenced by the same things: oxidative stress, inflammation, nutrients, lifestyle factors. So here we want to make sure we're providing the building blocks of sperm. I mentioned that's typically in the form of a multi, but to call out the specific nutrients that sperm requires for spermatogenesis: folate, B12, choline, zinc, selenium, calcium, magnesium, and omega-3 are all the critical ones. All nutrients are needed. These are the main ones. If we have low sperm numbers, so if we've had a sperm test and we know that we have low count or low motility or high DNA fragmentation or any of those things, these antioxidants are the evidence-based ones that can improve semen parameters. Do we need every single one? Probably not. Sometimes we do, depending on the stubborn cases and how elevated the levels are. We do not need to max dose everything all the time. So if you're taking a full strength CoQ10, we probably don't need full strength everything else too, because these things have synergistic impacts and they overlap, right? PMOS, this stands for polyendocrine metabolic ovarian syndrome now, the former polycystic ovarian syndrome. It is highlighted by a couple of common underlying factors. Often we see insulin resistance and issues with androgens, although not always. We use a supplement called inositol. That's the top one you see here, often for these types of circumstances. This is the most evidence-based one from a fertility lens for PCOS or PMOS and egg quality and ovulatory patterns and things like that. So that's a common one that you will see in PMOS or PCOS treatment plans. And then women with PCOS are also more prone to vitamin D deficiency and inflammation, so they might need more omega. And then the N-acetylcysteine is useful for egg quality and insulin resistance, so it can be beneficial in that population as well for those reasons. In terms of endometriosis, so in terms of our unexplained infertility cases in a fertility clinic setting, approximately 50% of those are thought to be as a result of endometriosis, for example. So it is quite common in that type of an environment. Although in the general population, we don't expect everybody's going to have endometriosis. However, inflammation is inflammation. So whether it's in your endometrium or other places of your body, these are things that we can consider for inflammatory type conditions outside of endometriosis sometimes. So omega-3 in therapeutic doses is very anti-inflammatory. NAC comes back to us again for the antioxidant and anti-inflammatory effects. Melatonin has an affinity for endometrial tissue, can create some benefit there. Resveratrol has been known to decrease oxidative stress in endometriosis tissue and potentially prevent it from growing. Curcumin comes from turmeric or spice, also an anti-inflammatory. So again, I would not use all of these in one specific patient. I might pick one or two and then layer it with that foundational support. Other supplements that might be helpful. So if you've been in the depths of Google and you've been, in the Reddit chats and things like that, you might come across some other things. So I'm going to call them out for you here so you know what's going on. So PQQ stands for pyroquinoline quinone. Nobody's ever heard of that before, but it is a synergistic agent with coenzyme Q10. Sometimes they like to put it in with CoQ10 supplements. And so whereas CoQ10 can sort of put gas in the engine, PQQ has thought to maybe rebuild new mitochondria. So it's an up and coming. It's used a lot in anti-aging medicine. There's not a ton of data on it from a human IVF data perspective, but it's definitely an interesting one that we're keeping our eye on. NMN or NR, which is nicotinamide riboside. There's a couple popular products kicking around out there that patients come in with. So this is an antioxidant. It's also used in anti-aging quite a bit, and there's only animal-based studies so far in terms of reproduction. So there's very, very little evidence from a human reproduction perspective so far. But again, it always is interesting when the animal data shows to be promising, and we're definitely paying attention to what the research is going to say about that in the future. Probiotics, the fertility community is very obsessed with endometrial microbiome or reproductive microbiome these days, lactobacillus levels, and just creating balance in terms of our overall microbiome. So probiotics can sometimes be helpful, not only for gut health or vaginal health, but also for endometrial health, implantation, ongoing pregnancy potentially. Alpha-lipoic acid is another antioxidant. Sometimes it's used in egg quality or sperm quality, especially if there's insulin resistance or something along that line happening. Creatine, we're getting a lot of talk about these days. We know this one as like a supplement for bodybuilders historically. And so it helps to sort of increase muscle mass if you're using it with weight-bearing exercise. But it's a mitochondrial stimulant and a mitochondrial nutrient as well. So it helps to, from a working out perspective, gives benefit from the metabolism of your muscles, but also works from a egg and sperm quality perspective as well. So evidence that those could potentially boost the mitochondria in those cells. So that's also an interesting area of research that's going on right now. I saw a study that resveratrol supplementation led to reduced birth rates and increased miscarriage rate. Did you see that study? There's one study that looks at resveratrol in decidualization of the endometrium. I think that one might be the one you're referring to. So there's basically a period of time right around implantation where there's a suggestion that resveratrol might be detrimental to implantation. So I use resveratrol strictly for egg quality, leading up to, say, a conception/fertilization, but not for implantation. And there's like always catch-22. Significant endometriosis might be treated differently, right? So in general, I would avoid resveratrol in natural cycles when you're trying to implant, and IUI cycles, things like that. And I usually use it in like IVF prep when we're doing egg quality stuff, and then I'll take it out for transfer cycles. I hope that answers your question. Are antioxidants, specifically CoQ10 and NAC, safe to take during the 2-week wait after embryo transfer? So yeah, they are. Now, the lens shifts a little bit. So I know some clinics actually recommend stopping them at egg retrieval, but you have to, so that is looking through the lens of we're using these products strictly for egg quality. And sometimes that is true. In the lens of an egg retrieval cycle, that's kind of the whole context of the cycle, right? But we also have to understand that these nutrients do other things as well. They're antioxidants and mitochondrial nutrients. They're not specifically for egg quality. So for example, there's some data suggesting that using 200 milligrams of CoQ10 in the 2-week wait can potentially help like with lining and implantation, like very little data. I'm not saying it's a strong study or anything like that. So I will often take it out for embryo transfer cycles and focus specifically on just stuff that's more evidence-based for lining, but it's not wrong to take it in that period of time. So that there's a difference, right? It's not detrimental. There's no evidence to suggest that it's going to impede implantation or anything like that. It's just more considered for egg quality. So if we're moving on to, say, embryo transfers and not using eggs anymore, we might remove it. But if we're doing cycles where we're using our eggs every 4 weeks, then we might want to consider keeping it in. I hope that answers your question. Supplements are not risk-free, so toxic doses do exist. So for example, things like vitamin A, B6, iron, they all have toxic doses, and if you take too much, it can cause some pretty serious stuff. Even things like calcium and vitamin D in too high of doses can be detrimental. So just being reasonable. In a multivitamin, it's generally not ever enough to cause overdoses. However, like I'll tell you a story that I just had happen to me clinically, is I had a patient, normal prenatal vitamin, didn't think anything of it, but her B6 levels are really, really high, and she's got symptoms of B6 toxicity, which is like tingling. So it can happen. Some people are just more vulnerable to these types of things. So if we notice anything, we got to look. High dose biotin. So I highly recommend avoiding hair, skin, and nails, gummies, and those types of things, which tend to be quite high in biotin. High dose biotin can affect some lab tests. So it doesn't cause you to have weird hormones, but it can make your hormone tests look weird. So it can cause like TSH levels to be off, pregnancy hormone, estrogen, FSH. So things that we use in the fertility clinic all the time. The amount in your prenatal is not enough to cause any trouble. We're not worried about that. We're worried about the additional biotin supplements that are out there that have like 1 to 5 grams in there, or milligrams, sorry. Those ones are not applicable for something like this. A prenatal vitamin has like between 30 and 300 micrograms of biotin, so just low doses. Other things like St. John's wort, many interactions with medications and things like that. Echinacea can have some medication interaction. So just being mindful about herbs. I tend to avoid herbs when we're using a lot of medications, especially fertility medications. Certain supplements, there's one called DIM. It's used to lower estrogen. A lot of endometriosis patients find it. It can alter hormones. We can't use that one during IVF cycles. And then certain things, somebody asked about the resveratrol already. Great question. Certain things can't be used at certain parts of the cycle. Curcumin or turmeric in patients with thin lining, not a good idea. We can't use red raspberry leaf tea after implantation. Glucosamine in high doses can impact egg quality. These are some things that, we want to be avoiding. And so again, consult a professional if you're not sure. Would creatine supplementation help with low energy levels? Maybe if you're also doing weight training too. You can, like, creatine only really works if you're pairing it with resistance training. Practical takeaways: start with the basics, match your supplements for the diagnosis, ask questions, and review everything with your care team. All right, so now let's see if we have any more questions. Can you speak to ideal serum ferritin levels? Anything over 50 is acceptable. Optimal is probably around 80 to 100, in my opinion. If you look at the reference range, some people will want ferritin, like in terms of normal reference range, around 100, even more. That's really hard in a lot of women. We don't get there easily with oral supplementation. So from a pregnancy fertility perspective, my preference is if I see a patient and they're moving on to do a cycle, I want it to be a minimum of 50. What about high ferritin? What's the balance? So there's different, depending on the lab, they have different reference ranges. So like the typical one goes up to say 275 or something like that. So if I'm seeing levels over normal reference range, anything over normal reference range, I would say is bad for high ferritin. Now, ferritin can be elevated if we have inflammation. And so like ferritin, if we have inflammation, iron is in our red blood cells. Red blood cells kind of break down, releases ferritin into the blood, and you can you can pick it up in the blood. So sometimes if you see high ferritin, it's not actually because you have high iron, it's because you have inflammation. So that's tricky, and you have to also do an iron panel in order to figure that out sometimes. Whoops, sorry, I didn't mean to change slides there. Oh gosh, I'm trying to read the chat and making my screen all go funny. Okay. Can you speak to creatine for cognitive benefits? So creatine has some benefits when you mix it with SSRIs. We've had some research on, so it can improve like how we feel when we're on SSRIs, which are antidepressants. And there's been some research in the last little while coming out on things like PMDD, perimenopause, those types of things. I still think we need to pair it with strength training to incorporate it into the muscles to get the benefit. But that's kind of what I know for that. Thank you. This can be tricky through GPs as Life Labs has their lower level of normal as less than 50. So they changed it in October or November of 2024. And so now it used to be 30. The cutoff was 30. Now it's 50. Can you please share ideal level for thyroid hormone? So I'm assuming you mean TSH. So really anything in normal range for TSH is acceptable. So it's anywhere from 0.35 to 4 in general. There are a few studies suggesting we want TSH lower than 4, so say under 2.5. They've actually recanted on that. And so the data, when they were doing that big study in the meta-analysis, they'd had studies included that had different reference ranges. And so when they kind of went back and reevaluated, there was no change in live birth rate or pregnancy rate or miscarriage rate when TSH was up to 4. So based on outcomes right now, as long as your TSH is in normal range, that should be sufficient. If you have antibodies, then maybe that changes things. Let's see if there's any more that come through here. I got about 6 more minutes, so if anybody has anything else, just load her in here. Thank you. Thanks for joining. I'm not sure where everybody is. I know, well, we've got people probably having their morning tea with me this morning, and then other people having afternoon tea. So, regardless of where you are and what you're doing, thanks for coming. Why has PCOS changed to PMOS? Because it affects all metabolic endocrine systems and not just ovaries. So it was kind of a misrepresentation when we were calling it, and there's no cysts. That's the other thing, right? So we were calling it polycystic ovaries when really it was just lots of follicles, not actually cysts. And so they changed it to polyendocrine because like we have ovarian factors, we have metabolic factors, like there's so many different like hormone systems involved with PCOS now. So that's where the polyendocrine came in. And then we realized it's more of a metabolic syndrome versus an ovarian syndrome specifically. So it affects the whole body, not just the ovaries. So that's the main reason.
Yes, this question is for me. So it's a perfect transition. Thank you so much, Jennifer. Thank you very, very much for this amazing presentation. I learned so much myself, so thank you very much. Yes, this presentation will be shared. We're going to send an email to all the people who registered to this webinar. So you're going to be able to watch it again on our YouTube channel, and an email will be sent to all of you with the link. So you don't have to look for it. It's going to be in your mailbox tomorrow. Thank you again, Jennifer, for everything. Thank you again to EMD Serono for supporting this webinar series and making it available to our community. Next webinar as part of your Fertility Guide webinar series will be with Dr. Cho. It's going to be about PMOS. So that was a perfect transition to the next one. It's going to be on July 6th at 8 p.m. And all the information can be found on our website, including the registration link. Thank you so much, everyone, and have a wonderful afternoon. Thank you again, Jennifer. Have a good afternoon.
Have a great day, everyone.
Thank
Bye.
you. Bye bye.